Well, I just received the green light here to start, and again, it's a great pleasure to be with you in this Aligners Intensive course. It's been a very intensive indeed. This is the webinar number 6, where we started this week with the first one on Monday, talking about the first protocols to treat crownings and spaces diastemas. And today, in my opinion, probably one of the classes that you I hope enjoy more about the class 2 protocols. Okay, for those who are joining us only for this webinar, my name is Daniel Ramos. I am orthodontist for more than 20 years. I am working here in Madrid, where I am right now. This is my new office, my new space. I used to be in the clinic with patients, and right now I am working in a digital world, doing treatment plannings for a lot of patients all over the world with our treatment planning service. And I'm using this experience to share with you, to share some protocols so you can learn more about this amazing technique. Okay. So remembering, just very fast, the first part of the course, 4 webinars about the first uh, strategies and the biomechanics tips about attachments, staging, elastic, diagnosing, everything to that will work as our reference for all the protocols that we are going to discuss. We already talked in the webinar number 5 about class 1 solutions for crownings, mostly, right? And transversal problems, and also when we have more space than we need. And today about class 2, which, in my opinion, nowadays is almost like the normal occlusion, because the last data we have been collecting and looking to articles and evaluating my patients in my clinic and patients that we have been working from other clinics here in treatment planning service for DSD, we can see that the majority of the cases that get to us, dentists, orthodontists, they are class 2 patients, right? So probably nowadays, I don't have the exact number because the articles actually evaluate a country, a region, but I can imagine that today we probably have more people class 2 than class 1. And we need to know how to deal with it, okay? Do we need for all cases to correct to class 1? Can we live in class 2, adjusting the occlusion? And what are the techniques, what are the biomechanics that we have available to facilitate, to make it more predictable with aligners, okay? So it's very polemic indeed, because if we evaluate what we have in the literature, okay, we have a lot of content saying that treating class 2 with aligners is not possible. For example, this article here from some colleagues and some from Brazil, others from St. Louis, they evaluated the correction, malocclusion, the class 2 correction, okay, with Invisalign. And the conclusion they had, let's take a look here in this yellow uh, part of the summary, is that no improvement were observed in the anterior posterior correction. Okay, so they concluded that the amount of anterior posterior correction in patients with class 2 was about 6.8%. Okay, so it's almost nothing. And if we only took these as our reference, as I already mentioned in the previous webinar, uh, it's not enough for me to treat my patients, right? But here another interesting point. If we take a look in this part here, okay, they are saying that all patients, okay, they finished with the first set of aligners. So this is the first lesson here. We cannot imagine that we can treat this complex and difficult occlusion with one set of aligners. Okay, even though we can implement a lot of strategies, a lot of protocols, a lot of different types of attachments, elastics, everything we have available, and we can get close to the ideal final position, we need to know that additional aligners are going to be necessary, and this is something you're going to see in the cases I'm going to share with you today. Okay, so as you know, I like to start my lectures with a question. Okay, and my question is it possible to treat class 2 malocclusion with aligners. So let's discuss about this, okay? The first thing, the class 2. We know that we can have several variations, right? We can have a dental class 2, we can have a skeletal class 2, we can have a growing patient, adult patient, we can have a class 2 with crownings that we need to also understand how to solve it, and with vertical components, vertical face pattern, with transverse components, anterior posterior. So orthodontic is complex, right? The malocclusions normally are complex. We don't have only one. Normally we have a combination of different facts, okay? And also, when we talk about class 2, this is an angle classification, right? And we are talking about an anterior-posterior relationship. We know that we can treat basically in 3 different ways, okay? We can do an upper arch retraction and move the upper back, okay? We can advance the lower arch, and we need to understand that it's very limited, only if we have a growing patient. Otherwise, we need to ask for help for other specialties such as surgery, okay? And we can have the combination of both, okay? So the diagnosing part is the most important. If you didn't have the chance to take a look in the webinar number 1, and I took this slide from webinar number 1, and it's going to be very useful for us to review at this point. We need to start our diagnosing process from the ideal, okay? And where is the ideal? The ideal, and please watch webinar number 1 again if you don't remember, or for the first time if you didn't have the chance. We are treating differently, at least here, where we are planning a lot of cases for a lot of clinics. We are not seeing the malocclusion itself and trying to figure out how to move to a class 1 relationship in cuspids and molars anymore, right? We need to first do a facial analysis. We need to understand the face. And if we have margin to move back, to procline, to move forward any of the arches, okay? And by understanding these and understanding where is the upper, right? The upper ideal that we are seeing as the stage number 1, okay? So this is the first stage, to understand the upper ideal design. The design is something that we can create, we can draw, and we can eliminate any interference, so we can understand exactly where is the best for the patient smile and the face, considering all the three-dimensional position, okay? So the first thing we need to do is to position in the ideal place the upper incisors, okay? So the upper incisor is going to be a reference for our diagnosing process to understand if we have a class 2 where we need to retract the upper, or if we need to move forward the lower, or if it is a combination of both, okay? So after doing these analysis and placing, and this is something you can do by evaluating the photos that I share with you in the first webinar, okay, by understanding that we need to take differently our photos, okay? So we cannot just use the same documentation we used in the past. We need to take different photos, we need to take different data, like scanning the patient, like doing videos, like doing CBCTs, right? Everything we can use to diagnose better, it's helpful and it is welcome, okay? So to understand the upper ideal, we need to evaluate in the anterior-posterior relationship, the relationship of the incisors with the lower lip and with the smile frame, if we need to intrude, to extrude. But for class 2 that we're talking today, the most important part is to understand the anterior posterior. Okay, so for this analysis, we need to evaluate the profile picture with the patient smiling. And also, we have the 12 hours picture that I shown in the first webinar, that we can understand very well if we have margin to move forward or to retract. So if in the patient smile, if in the profile of the patient, the anteriors, mostly the incisors, are in a good position, if the patient has this angle between the upper lip and the nose close to 90 degrees, in a good angle, to move back, we will make it worse, the patient's profile. So for almost all patients to retract the anterior is not a good idea. Very few patients they have the anteriors very proclined with a protrusive arch, and that we have margin to do this retraction. Okay. In this case, when we see the incisors proclined, we will see in the profile of the patient they are moving out. And in these 12 hours that we are looking the patient in a higher angle, we're going to identify that they are moving out and covering the lower lips. So we have a lot of reference to understand, okay, this is a case that we can correct the class 2 by retracting. Otherwise, we are going to make the patient's profile worse, and also we are going to reduce space. And this is something that we don't want to do, because we can create issues for the patient. We can create airway issues for the patients, and this is not good. Okay, so what we are looking for when we are talking about an ideal, we have the first, that is a design, and then the second, which is adapting the lower arch to this design. So here is upper, here is lower. Then we need to match the lower to the upper. Okay, so this is the important part. So after understanding the first, we are going to understand how we are going to treat this class 2. Okay, we have several protocols. Okay, we can, as I explained, when we have a growing patient, we have tools to use with aligners, and mostly Invisalign, to do advancement, mandibular advancement. Okay, and this can provide a better positioning of the lower jaw, and I'm going to present a case in this webinar today. We can use elastics, class 2 elastics. Those elastics can stimulate the lower arch to move forward and also to retract the upper. It will depend on the needs for each case. Okay. When we need to distalize the upper arch to move back, we can use a strategy called sequential distalization, which is our protocol here. Okay, I am at this point, we are with my team orthodontists, they are agreeing with me here to do this kind of movements in patients with aligners. If we don't do sequential distalization, simply is not going to happen. Okay, when the molar is in a good position and we just need to retract the anteriors and premolars and anteriors, we can add IPRs, and this is something that needs to be very well evaluated, the Bolton analysis, to see if we have margin to reduce and if it's going to be good the interproximal context. But it's something that I'm also going to present a case that I did this and it worked very well. We have extractions. Okay, I like to say that is the last resource. I like to avoid extraction as much as I can, because again, I'm going to reduce arch perimeter. I'm going to make it the perimeter of arch smaller and less space for the tongue, and we are being invasive, right? And also something that in the last webinar I'm going to do some spoilers, and probably a new project that we are discussing for next year, right? A course to talk about these advanced techniques. We can solve a class 2 with orthognathic, and today I'm going to show a case, and also with skeletal anchorage and SFOT, which means surgically facilitated orthodontic treatment, a technique that it's very welcome nowadays for aligners case, and more now that we have software showing the CBCT, we can see that the final position most of the times move the roots out of the bone, and in order for us to not limit our outcome, we can use these techniques to do bone grafts, to do corticotomies, and to improve the bone remodeling process so we can have a better outcome. Okay. Another protocol that we have been using, right, and actually the third one, okay, that I mentioned now, and it is our routine, we call staging. Okay, and here in this table, it's exactly what you're seeing, this route picture with a lot of lines. We saw in most softwares, right, that we can see here in this other slide, that is identifying the sequence of movements. Okay, because we can see when it is white, at least this is for Invisalign, probably other softwares represent it slightly different, but it's very important to have this to understand how the movements are happening. So since we don't have the third molars, and from the second molar to second molar, this one here, Okay, this 17 that we put in this here. So from this one to this one, the second molar, all are moving from aligner number 1 to aligner number 42. Okay, we don't have a sequential staging here because they are moving all at the same time. Okay, but let's take a look in the video. Okay, and you that understand about uh, biomechanics at this point, you know about orthodontics. Do you think it's possible for the full arch to move back as it is here, right? We have all teeth moving back together. Even if we use the elastic and the patient uses full day, this is something that in my experience is not going to happen. Okay, and this is a clean check, this is a software, this is a project that came from the company, okay, as an ideal solution. They are suggesting me to do this. Okay, uh, I don't have good experience doing this. If we want to only stimulate lower jaw growth, and if you want to stimulate some retraction, and the patient is a growing patient, and we have time for the patient to use 2 weeks the aligners, and we are not worried about time, this is something that can be done without the expectations that we are going to achieve this final position here that we are seeing now. Okay, so we are not going to have this in this set of aligners. Here we are creating a force system. Okay, so for us to solve a class 2 like this, after our diagnose that we need to retract the upper arch, okay, we need to understand that the movements needs to be done sequentially. Okay, so a representation of sequential movements is like we're doing here in this lower posterior, this quadrant. Look how different it is. In the upper, we are not moving much to distal, but in this case, we need to move the lower mesial. Okay, it's just a dental movement. We are not advancing the mandible just to improve the occlusion here. So look how the graphic representation in the staging table is. Okay, so this 4.3 start moving from line number 1, and then the first premolar, this one, you start moving when the cuspid achieve is about 33%, and then start the second, and then the molar, and then the other. So we don't have all moving at the same time. This way, I'm going to explain you better with the software, but we are going to have always more crowns, more teeth being used as anchorage to move less teeth. Okay, that's the purpose of doing a sequential movement. Okay, so when it's not possible to move all at the same time, because of course every time we do sequential movements strategy, we are going to increase the number of alignments, because if we are moving out at the same time and from the beginning, we are going to finish each individual tooth movement sooner. Okay, but if we need to wait one to achieve about 50% of its movement to start the other, of course we're going to increase the number of aligners, and although it looks like a bad idea, it's going to be much more predictable, and actually it's going to happen in the end. Otherwise, if we try to do a magical solution moving out else, we won't be predictable, and it's not going to happen, and we will need to order additional aligners, and the treatment is going to be longer, right? So we need to understand when we need to order additional sequential movements. Okay, so here for mesial and distal movements, usually we use this protocol to do sequentially, or only if we have a very good skeletal anchorage, very collaborative patient, or using a device called Carrier system that we can block a segment and move them together, and usually they use this with an SFOT technique, but this is a topic for another lecture. Okay, but usually we use this kind of strategy for mesialization and distalization. When we need to correct a crossbite in mixed dentition, okay, so we don't want to lose or to put much force, we want to create a stable expansion. Usually we first expand the from the serous molar to cuspid, and leave the permanent molars there as an anchorage, and after finishing this we move the molar and expand. okay, another situation. When we need to do anterior retraction, I like to, it's possible, a lot of doctors, they retract from cuspid to cuspid, it's possible and sometimes it works, but I like to first start the movement with the cuspids, and then when they achieve 50%, I like to retract the incisor separately, okay? Uh, a case that we saw already, okay, when we have the anteriors retro-incline and we need to intrude. So if we don't create a staging to first procline them, moving the root axis inside the bone and then intrude them, that is going to increase the number of aligners, but we are going to protect and we're going to intrude only when we have the root inside the bone, okay? And also for anterior extrusion with procline teeth. If we start extruding without bringing the crown back and moving tooth inside the bone, we are going to extract and not extrude, okay? So a lot of situations we need to use this technique to improve predictability, and since distalization, which is a very common strategy, movement used in class 2, and also mesialization when we're talking about the lower arch, we are going to see a lot in the case I'm going to show, okay? But I like to start easy, right? Let's start with a more simple case, although challenging, because this young lady here with her 15 years, he got to my office a few years ago with her mother, and she was about to complete 15 years, and she has her, it's very important in Brazil this date for girls, and she has a huge party coming, and she wants to improve her smile and fast, right? And here we can see close her smile that we have a lot of asymmetries, okay? So we have different sizes and length on the crowns, disproportion in the exposure of the crowns, and a canted smile, and we had a class 2, okay? So this is an easy class 2 because it's unilateral, okay? We only have the class 2 in her right. It's a small class 2, okay? And we have the molar in a good position. So this is a favorable case for us to use not sequential movements and to move all at the same time, because we have a lot of teeth, because since the right side, the left side here, we have a good occlusion, okay? We don't need to worry about distalizing these, and we can use all these block as anchorage to move this block back. And again, we have this molar here in a good occlusion, as we can see here, right? It's in a class 1, and we need only to add IPRs. In this case, she has big crowns. We study she has margin for to do that, so we can create space, so we can move back these and correct the midline to her right, okay? So for this case, in order for us to solve this, we need to do this correction, midline correction, distribute, expand, improve the occlusion, and also in the end, she doesn't like her gummy smile. We will complement this in an interdisciplinary way with crown lengthening, okay? So the case here, she also has a big overjet, as we can see, okay? But I don't have any intention of reducing a lot her profile to make it worse, okay? She has procline her incisor, so we have margin for some retraction, but look how beautiful is her smile here. It's a perfect smile, okay? Sorry, the profile. So this profile I don't want to change, never, okay? So my concern here is to do the movements to improve the occlusion, to make the case ready for the final crown lengthenings, so we can really increase her smile, fill her smile with her upper tooth, right, upper teeth, without retracting the upper arch, okay? So this case we have 17 aligners, okay? 17 aligners is a fast case. So for her, she wants to do fast because of her party, okay? So usually the estimated treatment time for 17 aligners is 8 months, but we invested for her in this 3-day aligner change that you can see here, that we use with a technique that we call MOPS, micro osteoperforations, okay? So this is something that I use to her in order to accelerate the case, and then it can change faster. Sorry, I clicked the wrong button. And back here, just for you to have an idea, I treated her in 2016. She got to my office in March, okay? In Brazil, and until she can make out the documentation. I didn't have a scanner at the time. It took about 2 months for me between talking the first time to the patient, doing all the photos. We send out the files to Invisalign, and I have the software, the CleanCheck back. It took 2 months, okay? And you can see here in the other side of the screen, the right side, October 16. This is the deadline her mother informed me. Daniel, you need to finish by October. So okay, let's see if it's going to be possible. Okay, another bad news for me, right, and of course for the patient, but I was under pressure, right, is that for in Brazil at that time it took about 2 months for the aligners after we approved for the aligners to get to my office. So between March and October, we had 7 months, okay, in a treatment with 17 aligners that normally would take 8 months, and we only started the treatment 4 months after. So we actually had 3 months, okay. So these 3 months, I need to do an 8 months treatment, and my colleague who is going to perform the crown lengthening asked me about 1 month to have everything healed for the party. So in the end, I had a patient, young patient, beautiful patient, with her mother putting a lot of pressure to do a 17 aligners and to achieve a good occlusion in 2 months, what usually we would do in 8 months. Okay, so it's impossible, right? And at this moment, thanks God, I was just coming back from United States, where I was talking to Propel Orthodontics, which is a company based in Silicon Valley, right? And I was studying a lot for years their system about the micro-osteoperforations. And with micro-osteoperforations, most doctors can change aligners in about 3 days. Okay, so this is something that it would fit for her, because 17 aligners in 3 days we can finish in 51 days. So I explained to the patient, to her mother, and I explained as the only way for us to improve the predictability and be able to change aligner faster, okay, without compromising the outcome. Okay, and they accepted, because a teenager, 15 years old, grow with some goal, she can do anything to achieve it. Okay, and she accepted. And this procedure, just for you to have an idea, we do tiny little micro perforations with this specific device that you are seeing here, right? This is something that developed by Propel, and is very safe to the patient, heals very fast. Okay, and all the areas you are seeing we did to increase the bone remodeling process, to allow us to change aligner faster. Okay, and let's take a look in the biomechanics for her. Okay, let me move here, and I'm going to open. So it's not this case, this is another complex case. I always tested these, and during our webinars takes a lot of time, probably because of the connection. Let me just wait a little. If not, I'm going to open there. Okay. Okay, Georgia. Here we have. So you can see that we have 17 aligners, as I explained. Okay. Let's take a look in her malocclusion. Here we can move and see that although it looks like it's not a big class 2, but actually it's more than we think. But luckily for her, we had this occlusion. Okay, I added a lot of IPRs, 0.5, 0.5, 0.5, and the anteriors also, last but also I added. Okay, so the lower arch is not a big deal, but in the upper, what we did, okay, we moved. Let me move here. Okay, I am not moving the molars, almost nothing. Okay, and using IPRs to correct the midline. Okay, as you can see, the movement, expansion, and everything moving at the same time. Okay, with this, let me put in a frontal view. Okay, what we did, we close the open bite, and we are going to see a webinar just to talk about these and the strategies. Okay, but look, we are adding IPRs and closing and moving the midline to her right. Okay, and also here in this profile picture in the bikini. Okay, and with the IPRs, without changing the molar relationship, we could do this correction. Okay, let me move back here and put back to the presentation. So 3 days after the day we did the micro osteoperforation procedure, we bonded the attachments, and we inserted the aligner number 1, I asked her to come back to my office to try the aligner number 2. Okay, so here we can see that we have the aligner number 2 in 3 days with a good aligner seating, okay, with a good tracking. We cannot see spaces between plastic and the crowns. So this is everything I want to see in this appointment, okay. You remember every area that I present to you that I did the microscopic perforation. So we almost cannot see here. You can see something healing, but in 3 days it's almost like I didn't do anything. Okay, it's super easy for the patient. Good tracking, and the patient could change the aligner in 3 days without feeling any discomfort or pain. So otherwise, without this technique, it would be impossible. Okay, and here after the 17 aligners, where we got, okay, in 51 days. I was super surprised. The mother was excited. The patient was happy, very happy, because we could finish these 17 aligners with a lot of collaboration from her, but also because of these strategies in 51 days. Okay, look how we could solve here the class 1 in the cuspid, the midline, and I want you to pay attention at this open bite here, okay? Look to this and what I did in this case. For this case, and this is a tip that I can do for you, provide to you, I tested something because I didn't have the time to order additional liners. I didn't have the time to bond buttons here and use elastics, right, to close. What I did, I simply cutted the aligner in the lower arch because the upper was good in her face, and I want this and this to extrude. So I cut the aligner and remove all this part back, okay, and I ask her to use the upper aligner and the partial aligner in the lower from this to this from this cuspid to the fourth quadrant, and leave this segment here without any aligner there to let the occlusion, the function, to work. Okay, so let's see how it ends this after 1 month. Okay, and here's the difference between the overjet we had and how we plan and where we get. Okay, so the comparison between initial and final. So we have a treatment that normally I would do in 8 months that I could do because of this technique in 51 days, the Propel microscopic perforations. Here we can see the difference now is initial, final ortho. So the ortho could improve a lot of factors, right? We could improve the smile frame, we could improve the distribution, the midline, but the asymmetry here of her crowns is still there, right? So we need to complement with the crown lengthening. And look how beautiful it is, how natural it is, very fast, okay? And here, remember the open bite, and look how it is right now. And what I did, I just cut the aligner there and let the nature, right, work for me. So only by her using the aligners, biting every day, we could practically close this open bite without any appliance, right? Just the nature doing her job. And here's the final occlusion, how good it is. So in a closer view that we could correct class 1, beautiful occlusion. Okay, the predictability between what is planned and what we achieved. Okay, what is planned in the software in the right, and then in the left what we achieved, very close. And here her smile after 51 days of ortho. So if you remember, it took more time for the alliance to get to Brazil than the time that we did use to treat her, right? Amazing. So the total time was 51 days plus 30 days for whitening and crown lengthening. So we are talking about a very fast treatment, very straight to the point, understanding that doing the correct diagnosis and avoiding movement where we don't need, and adding strategy to achieve this. Okay, after 3 years and a half, we could check her and she was very stable. A minor relapse here because she was not using her retainer. Okay, so this is her fault, and then we use some additional lines to finish and to correct back this to the position. Okay, but after 3 years we could have a very good occlusion and stable. Okay, a lot of doctors ask me, Daniel, 3 days and the root resorptions. Okay, the microscopic perforation create a better bone remodeling, so we are actually protecting the roots. She also had ortho in the past, so she has some, she appeared to me with some research in this area. We could keep them exactly the same. We didn't improve them. Okay, if you look here, this lateral here, okay, we have the same characteristics here. In my opinion, it's including better after ortho, and after 2.5 years, very stable without any root resorption. At this point, she heard me and she's extracting the third molars. Otherwise, we would compromise these areas. So she now is out of the third molars. Okay. Now let's make a little bit more complex. Okay. This is another patient. Okay. We can see that she has a profile that is not straight, is more concave. Sorry, it's more convex, and it's good. At least in Brazil, research was done, and the women prefer more volume in the lips. I think in Brazil, probably a lot of other places, right? Nowadays, it's kind of exaggerated this, but we didn't want also to change this. Okay, but we had this bilateral class 2. Another patient that did orthodontics in the past, and she uh, didn't wanted to do more braces, right? She wants aligners. Okay, so again, let's move here. Let me close a while, and I'm going to move. Okay, and this is this patient. Okay, let me close, and this is just for you to have an idea. We have in the software the history of the case, right? So we can see a lot of plans that we did. So you can see that it's not easy to do in one shot the treatment planning for a patient in a case like this. Okay, in my case, until I approved the first ClinCheck, the first software, I did 3 simulations here. The one from a line and do modification until I approve the third one. Look here at this point to finish the case and fine tune. This is my job here. It's not a software, not artificial intelligence. Okay, but moving to the plane, I did. Okay, just for you to understand how differently the teeth moved. We have also this table, so we are explaining the movements each tooth is doing. So we are talking about mesial distal translation. They are distalizing about 1.8, 1.7, 2 millimeters. Here in the left side, 2.5, 2.4. So we are talking about a 2 millimeters class 2, okay, that we can see here. Let me close this table now that you already know. Okay, and then we can see better. Okay, so what we want to do for her, I want to move back a little bit, okay, to open space to solve the crown. So what I need to do is to do these sequential movements. Can you see that all the anteriors, they are not moving here? I'm going to do something that is going to facilitate the visualization. So this overlapping here, let me put, when it's in this gray color, okay, is because it's not, it's in the, here is the initial position, and then I'm only moving, it's changing the color because it's moving, okay? It's overlapping, now it's not the same position. So I'm only moving the second molar, okay? And then I start moving at this size, the first molar, and then I start moving this. This one took a little bit more time, okay? So I always have a large group of crowns being used as anchorage, okay? Here, maybe why I needed to do a lot of testing and refinement, I did 2 refinements, because I try to speed up this process. So you can see that at one point we had all four here, 2 premolars and 2 molars moving at the same time, and only using the anteriors as anchorage. So this kind of situation sometimes move the anteriors forward first, and then when we need to move back, and we cannot correct fully the class 2. Okay, but still it's a sequential movement, and it's better than moving out at the same time. Okay, I only start moving, okay, the anteriors after finishing the movements in the molars and having at least 1, 2, 3, 4, 5, 6 posteriors being used as anchorage to move back these anteriors. Okay, so this way we can have a good anchorage system. And of course here I am overcorrecting this retraction. I don't expect to have this amount of retraction in a patient like her. But in the end, we can see clear the anteriors, the incisors are not retracting that much. Remember, I don't want to make it worse her profile. Okay, so comparing to what we got in the first set of aligners, I'm going to compare here. Okay, I'm sorry that is in Portuguese. Probably the other case is going to be in English here. So we are going to see that this is how this is the scanning after the first set. So in terms of shape of arch is very similar, okay, but in terms of class 2 correction, we plan to achieve this class 1, okay, from here to here, and we got halfway, okay. The molars are good, but we still need to distalize a little bit more. Remember, we don't have any one shot to make it right, to make a holy one. We can use and we should use the additional lines, okay. In this left side, we lose tracking a little bit more, okay. So here, this is the plan that I approved for her in the second stage. Let me open, sometimes takes a while. Okay, let me remove here. And let me see, if you don't open, I just want to share with you. Sometimes the connection is not good. Okay, the last one. So here we got, after finish this set, okay, so we just want now to fine tune to finish the case. It's a class 2 still. We couldn't achieve the perfect class 1, but we could improve the occlusion, the contacts, and this is before the last additional liner, okay. So this case I can see two factors that probably compromise the treatment, okay. One, I move a lot of crowns at the same time, okay, and the second one, that the patient sorry, something happened here in the connection. Let me move back to the presentation, and then I'm going to explain. The second one is to that the elastic, probably the patient didn't use it very well, okay. Then we have more complex class 2 in my opinion, because here we can see that we have both class 2, a lot of crowning, and also a crossbite, okay. So this is the kind of case that we need to do a lot of complex movements, and the sequential movement helps a lot, because imagine we trying to expand, distalize at the same time, okay. If we do all of these posteriors at the same time, it's not going to happen, okay. So this is an interdisciplinary case. We have some crown lengthenings, we have restorations in these blue anteriors. The molars, we have a benefit to in the plan not to change, but of course in the clinic is another thing, okay. This is the case that because we have the right side not moving, okay, and because we use also some SFOT technique like micro osteoperforations and vibration, we could achieve a good result, okay, using this kind of accelerated sequential movement, okay. So let me move here, and oops, this thing about changing from one software to the other kills. Okay, sorry. Okay, yeah, live and connected, it's like this, okay. Why I don't have? So here is the final outcome, okay, after doing this 33% of distalization. I have an issue with the software in this one. After finishing, if you have time, I move back and can show, okay. But what I did, the same way the other case, I used the 33% sequential movements. I'm going to explain a few how to order these, if you're using Invisalign, if you're using Spark, or if you're using any system, okay. But the 33%, when we talk about 50%, is because we are going to start the next movement when the first achieve 50% of the total movement that we plan. 33% is when the second is going to move after 33%. So in 33%, we can have 3 teeth moving at the same time at one point, Okay, more than this is more complex. Okay, but this is the strategy. Here in the green model is the simulation of the final outcome, and here is where we achieve it after one set of aligners. Look the expansion and look how well it is. Okay, so for these cases, right, that we need to do the stylizations for class 2. The sequential digitalization, right, is very welcome in the class 2 cases. We can have good predictability, okay, it's very good for digitalization until 4 millimeters, and also for unilateral digitalizations. When we have more than 4 millimeters, it's time for us to think about adjunct therapies more than just this strategy, more than just using elastics, okay? We need to think about using skeletal anchorage or even some more drastic solutions with SFOT or also with surgeries, right? So for digitalization above, include skeletal anchorage as a protocol. This is a good tip. Less than 4 millimeters, sequential movements, and elastics. More, it's mandatory to use skeletal anchorage. Okay, Daniel, but can I use skeletal anchorage for digitalizations that are less than 4? Of course you can, okay, because you can have a better predictability, right? You can have a good predictability and a faster treatment for cases like this, okay. I like to use for regular cases when we have bilateral digitalizations for class 2 and the right and left side, the 50% protocol, right? The 50% pattern of movement, and the 33% for unilateral class 2, or when you are adding some SFOT technique like corticotomy, microsteal and vibration can help, but mostly for cases that you have these kind of surgical facilitators, right? And how to order. You can order by writing, right? Because most softwares don't allow you to change and to adjust these. Some can, okay? Those that can do this, SureSmile, for example, for some time, you can adjust all the details of the staging. It takes a lot of time, okay? But you can do. But I prefer writing to the technician because this is the part that they do better, and we can gain a lot of time if they do for us. So I normally write these: do sequential digitalization on teeth, then you need to describe the ones that you want to do this strategy, okay. I like to be very detailist about it. I say it's kind of obvious, right? If we are doing sequential digitalizations, it's obvious that the 1.7 is going to be the first, but I like to write anyway, okay, and then I explain how they need to move, okay. So I'm ordering the group, which one we need to start, and then the item number 3, start moving on 1.6 when 1.7 achieves 50% of its movement, okay, and use the same pattern for the subsequent movements. This way it won't be any mistake, okay. They are going to understand and they are going to do, okay. I already present to you a case that we did 33%, a case with 50%, that kind of I couldn't show well, but it's possible to move faster, right? It's possible to accelerate the sequential movements more than 33%, like move 25%, uh, and this is the case that you need to evaluate if it's worthy or not, okay. For this young lady here, she is a class 2, okay. We can see her cuspids tipped forward, right? Very characteristic, and almost a complete class 2 that we need to correct. We need to do a lot of strategies here, okay. For this case, you can see in the video the clean check, okay. We are doing the sequential digitalization. I will try to open the clean check. I hope that we can. For this case, the other, it was blocked there. I don't know what happened. I tested before, but and then I'm going to show everything, the details. So look the sequence of the movement, so how much we are retracting. The first stage, 48 aligners in the upper, 34 in the lower, a protocol of 10 days, okay. And here initial, okay, how much we digitalize, and at least we plan, and where we get a huge improvement, but we did the lower arch, a huge improvement, but we couldn't solve the case, okay? She still has her cuspid and she still has a minor class 2. In the second stage that we did the microosteoperforations to finish the case and 25 aligners, and then we changed in 3 to 5 days to finish and achieve the ideal occlusion as we are going to see here, okay? So let me, I hope now I can. Let me click here. Okay, here it's opening. Everything is working. Let's not panic. So I just want to brainstorm about some ideas here in this case. Okay, so it's opening here. Hope it won't change. Let me see if the other is better. Okay, we have it open here. So this is her case, the last one, but I want to move to the first, okay? The initial configuration that came from a line, if it opened, okay? If not, I will need to move back to this one. In just a second, I'm going to use to have some water. Yeah. Just a second. And we tested, right, Valeria? Okay, I'm not going to waste time here. And then we can move back later and test to right to open. So what I want to explain here is for us to do this sequential movement that I hope at this point you understand how can we write in order. The safe mode is to achieve, and this is the final outcome that we could achieve, okay? And this is her smile, the change, okay? Corrected the cuspid, very natural. She didn't want restorations. Uh, and the first phase was long, 48 aligners, okay? So she complained a lot about these 13 months. And then when she discovered that she would need to use more 25 aligners, okay? She freaked out, and then we explained to her that with this technique she can we can try to move fast, okay? So we did very fast aligner changing in 3 to 5 days, and we use a lot of elastic, and we did as an emergency situation. I'm not saying that I am recommending this, but this is what we do when we have a patient almost burn out about the treatment. So the only way I can do the 33% or even 25% protocol for sequential destabilizations is when we have any SFOT technique. In her case, it was a refine. Okay. For growing patients, we need to understand that we can work with their growing, right? We can work in our favor with the lower jaw to stimulate to grow, okay? And this is not new in orthodontics, okay? I like this term, not new in orthodontics. Sometimes a lot of doctors, they think, oh, this is a new discovery, the precision wings for Invisalign, this is something amazing, but we have this for a long, long time with other appliances, okay? The orthopedics in orthodontists, they are here for years and years and years, okay? Very old, to stimulate mandibular anterior posterior position, okay? With aligners, what changed, and this is something that we need to say congrats to Align, because the idea is amazing, to use these wings. You can see this is in the upper, okay? And we have this ramp that every time the patient bites, the lower also has this wing out, okay? And then it starts stimulating to move forward, okay? So it's very important, because this kind of patient, class 2, usually they have also a deep bite, okay? Because the lower jaw is more retrognatic and the anterior start to extrude. So to try to stimulate any mandibular advancement before correcting the vertical first is a big mistake, okay? So we need to understand that for us to do this, to stimulate the mandibular growth to advancement, okay, we need first to correct the vertical. So, and also any interference that we have. So we need to expand, we need to level the speak curve, okay, not a speed curve, the speed curve, and also verticalize upper incisors, okay. So we can, in case that we have a class 2 second division like this, that they are retro inclined, so we need to open space, we need to solve the vertical and open space, so later the orthopedics can have this space to stimulate the mandibular advancement. Otherwise, it's not going to happen, okay. So after correcting the vertical, we're going to use this strategy, and again, this is something that is for Invisalign only, right? And you can use any other appliance orthopedics. You can use a first stage of aligners to correct the vertical, and then you can use the orthopedics, so it's going to work. But with Invisalign, you can order everything at the same time. So you can see here that we are stimulating with this ramp to the lower to position more forward, okay. So this is something that it comes in the plastic, so the aligner is going to come with this extension, right? The upper this big one and the lower this smaller one, so the patient is kind of in the first days discomfort, but young patients, they get used very fast, and they are going to start stimulating to bite more forward, okay. So this ramp here and this one start change the position, okay. As soon as we are stimulating, we are going to stimulate 2 millimeter advancement every 8 stages, okay. So after 8 aligners, this ramp is going to move slightly forward and then stimulate even more forward the position, okay. And patients need to change aligner in 2 weeks ideally, okay. So we do this in 3 stages of 8 stages. So 8 aligners, then the precision wing moves forward, and then more 8 aligners, and then move forward. So we have 3 stages, and at the end we can improve a lot, okay. So this case, this is a patient that is of course a class 2. We can see everything that I explained: extruded incisors, deep bite, okay, 32 aligners. So we have here these very extruded curve SP procline. So this case we also can retract a little bit the uppers, because look at his profile, okay. So here we can see it happening, okay. So this is one of my first cases, and you can see that everything is moving at the same time, okay. We are correcting the vertical from the beginning, but we start advancing as we are opening space. Nowadays I prefer to be more we have more precautions, right? So I prefer first correcting this vertical and then start this process. So you can see here that we have 3 jumps. This arrow here that you can see is the first, and then the second, and then the third, and then we finish the case, okay. So here again, the first, and then changes here a little bit more forward, and then a little bit more forward again, and then we can finish the case, okay. So we can achieve this final occlusion in one set of aligners, okay, a huge difference. So here is almost in a class 3. Of course, we have a deviation. We need to still finish the case, okay, but we could improve the profile. Look at the position here of the incisors compared to the previous one. Let me move back in the previous one, how it was here, the distances, right? And look here the gap that we have and how it is right now, okay. So this is only one set of aligners that we could improve a lot of space, we could position the mandible better, and now it's much easier for us to use elastics and to finish the case, the occlusion, okay. So I highly recommend this for growing patients for class 2 in this phase when the patient is still growing, to stimulate this mandibular advancement so we can open space and avoid upper arch retractions to reduce space, okay. Then we'll have more content about this in another webinar, okay. So it's good for you to stay tuned, okay. Here we have the challenging case, right? It's much more challenging, the decision-making process, than the case itself, okay. Of course, you need to have good people with you in your team to do a orthognathic case with aligners. The aligner is not a problem because actually my surgeon prefers that I'm preparing cases with aligners, but the diagnostic part is important. And when we understand, and I'm not going to to use a lot of time to show all the treatment planning. This is something we already did in the first webinar. But when we understand that this patient, okay, with this occlusion, big, complete class 2, okay, this is the occlusal view, okay. So if we only evaluate the occlusal view, we can see, okay, this is a simple alignment and leveling case, okay, it's not a complex ortho. Then the x-rays, and here the ClinCheck, what we did to move her, because when we understand that it's not possible to correct this patient with orthodontics, and we are not going to concern with orthodontics to correct the anterior posterior, this becomes a very simple case, because the ortho is going to align and level, and this advancement that you just saw here is the surgeon who is going to do, okay. So this is a diagnostic part, okay. So for this patient, we evaluating her profile, she already has an open angle here and very retrographic lower jaw with sleep apnea issues, so she needs to open space. We decided to move on with the surgery, okay. So we prep her in 27 lines total, okay, the lower active only 16 to align and level, and then she went to the surgery, okay. This is how the surgeon asked me to prepare the patients, okay. So I bone a fixer retainer here in the lingual and buttons for him to use elastic, and then she's ready for the surgery. Here the surgery done, okay. And here the final occlusion right after surgery, Dr. Otávio Sintra from Brazil, okay. Here she is still with some residual composite. We need to polish everything, but right after finishing the treatment, and how it improved the occlusion, okay. So here before and after, the profile, a huge difference, very beautiful. This is in 45 angle. Look how deficient is her to close her lips, okay, and smile. She also asked us to be the less invasive possible. So when talking about orthodontic surgery, and we are talking about being less invasive, but to compensate this case, right, to move back roots, to move out of the bone, it's going to create a huge problem to her, okay. I'm going to try to do the last attempt here to show you a case, but it's not responding, okay. Let me see here. I think this is the one. Yes, now I could. I hope it work. Okay, so we have this case here, for example, okay. This is a class 2 also. It's very similar to the case that I just shown to you, okay. For this case, the ClinCheck is deciding here to correct, compensate, as you can see, as the final occlusion, okay. So this is going to happen. This retraction is good for the patient. If we did this in her case, we would close more space. It will make it worse for sleep apnea, reduce space for the tongue. It's going to be very bad for her, okay. So in this case, if we cannot move back these anteriors, we would need to procline these lowers, okay. And do we have space to do this? Let's take a look here before and after, and the overlapping between the movement that we are doing. Although it's not much, okay, we are talking about here some intrusion, okay, and some difficult movements, okay. So here, let me see aqui, this, okay, yes, and this is the case, right? Another situation, okay, again the same thing. Imagine correcting these like the ClinCheck is showing here with this advancement, okay. This is the case that I want to show, sorry. It's pretty much the same protocol here to move the lowers forward and retract the uppers, okay, without orthognatics. The software is going to say that it's possible, okay. So taking a look here now at the differences, okay, look how much, look the transparency between the original position and how much is proclining to get to this position, okay. So what we are not seeing, and more we will have available, is how is the roots in this story, okay, in this history. So by bringing the CBCT here, we can see that the roots normally are moving out, Okay, so we need to understand if it's worth it to do this. Okay, a lot of doctors, what they do when they see this, instead of talking with the patient about some strategies, some orthognathic surgery, they prefer to move back the roots. Okay, and it's not correct, because we are going to limit and reduce space. So if we diagnose the upper arch is in a good position and we only need to move forward the lower, the decision is how can we do this? If it is a growing patient, we are going to uh, stimulate mandibular advancement. Okay, if it is an adult, we can accept the class 2 if it's possible. Okay, and this is going to happen if the patient doesn't have any complaint about TMJs, about airway. Okay, we can, depending on how much we need to move forward to cover these roots here, okay, that you can see, okay, we can add bone graft in this area to prepare the area in order for us to be able to move in this position. Or when we have more to advance, it's only with orthognatics, okay, but never change the upper if it is in ideal position, mostly when we need to retract. Okay, but this is something that it's not going to be good for the patient. Okay, so I'm fighting with the software. I would like to exemplify how can we move back with the tools. I don't know what happened the connection. Okay, but this is the case that I want to share with you, and the information I wanted to share with you about class 2. Okay, so for simple cases summarizing, and at this moment Valeria can start thinking if we have any questions. Okay, uh, uh, we have for simple case the possibility to add IPRs if we cannot, if we're not moving molars and it's just a cuspid class 2 correction. Okay, we can, for more complex cases that we need to move molars, sequential movements, it's very important when we have margin to retract the upper. Okay, if the upper is a class 2 but the upper is good, then we have the 3As that I mentioned, or to the 4 actually, or if it is a growing patient, to stimulate mandibular advancement, or if it is an adult patient, we can understand and accept the class 2 if it's possible, to add bone graft and SFOT techniques to create a little bit more margin to move forward the lower, or orthognathic surgery is the road to the success. Okay, I surpassed a little bit of time today, but I hope you enjoyed. I'm really sorry about the case that I couldn't open correctly the ClinCheck there. I promise to solve this issue for next webinar. Okay, probably about the connection today, and I'm here. If you have any questions, please let me know. Otherwise, you can send the questions later. Okay, and I will respond with a lot of joy. Let's give more time. And let me see. The team is typing. I hope it is a question. Okay. Okay. So you know that everything is recorded. For those who subscribed, you can watch it later again if you miss some parts. And if you remember any question, anything you don't understand, please don't hesitate to write to OHIS team. They are going to forward the question to me. Normally I answer very fast, and I hope you enjoyed, and I hope to see you soon. Okay, so bye bye, and thanks for your attention.